In this lecture, we will study about the pathophysiology of the heart failure. Okay. So the heart failure occurs when the heart is unable to put out an amount of blood that is adequate for the needs of the tissue. So the heart failure does not mean that whether the heart is working good or not, even if the heart is working sufficiently good, but if the heart is unable to provide the blood that is required for the tissues, then we call that condition as a heart failure. Okay, so it can be acute, okay, associated with a sudden death, or it can be chronic. Okay, so the failure may involve primarily the right ventricle. So if the right ventricle fails without the failure of the left, then we call that condition as the cor pulmonale. Okay, and but the most common condition that can cause the right ventricular failure is the left ventricular failure. So, but much more commonly it involves the larger, thick left ventricle or both the ventricles. Okay, so the heart failure may be classified as systolic versus diastolic. So let's see the differences now. The systolic versus diastolic heart failure. So in systolic failure, the stroke volume is reduced. Okay, the stroke volume is reduced because the ventricular contraction is weak. Both, even in diastolic, the stroke volume is reduced, but the stroke volume reduction in systolic is much fast and evident, immediate effect. Okay, and this causes an increase in the end systolic volume. The end systolic volume will be increased in this scenario. So the ejection fraction falls. The reason for the end systolic volume is to increase the ejection fraction falls, and it falls from around like 65 to like around like 20%. Okay, so the initial response to failure is activation of the genes that cause the cardiac myocytes to undergo hypertrophy and thickening of the ventricular wall. So this we refer as the cardiac remodeling. Okay, the cardiac remodeling. The incomplete filling of the arterial system leads to increased discharge of the sympathetic nervous system. So this is the first compensatory mechanism that you get, increased discharge of the sympathetic nervous system. And then there will be the second compensation that we get is the renin angiotensin aldosterone system. Okay, so the second one is the RAS. Okay, increased secretion of the renin and aldosterone. So the sodium and water is retained. Okay, this is because the blood is not reaching to the blood vessel. So actually what the body is trying to do, it is trying to overload the body. So these responses are initially compensatory, only initially. Okay, but eventually the failure worsens and the ventricles dilate because already failed and you are adding more volume to that, okay, to the system, and that is why the ventricles will dilate and fail furthermore. Okay, so let's see what is the diastolic failure. Okay, so in the diastolic failure, almost a similar thing, but here the problem is in the relaxation. So the ejection fraction is initially maintained, but the elasticity of the myocardium is reduced. So filling during diastole is reduced. Okay, so this leads to inadequate stroke volume, same like that in the case of a systolic failure, inadequate stroke volume, and the same cardiac remodeling and sodium and water retention that occurs in the systolic failure will happen. Whether it is systolic failure or diastolic failure, both of them is going to happen. Okay, so the sodium and water retention, so initially starts with the sympathetic and then it goes to the RAS system and the sodium and water retention will happen. Okay, so it's about the diastolic failure. Now let us go to the high output failure. Here the heart is working good. Okay, the high output failure. In the high output failure, what happens? The heart is good. Okay, but the inadequate cardiac output in failure may be relative rather than absolute. So for reasons something like a large arteriovenous fistula, okay, or due to thyrotoxicosis, or due to thiamine deficiency, the beriberi condition. Okay, so these conditions, the large arteriovenous fistula, so the heart is pumping the blood because of the fistula from the larger artery directly goes into the veins, so the blood does not reach into the capillaries and to the tissues. Okay, so even though the heart is pumping, the blood is not reaching to the tissues. And also in thyrotoxicosis on the or in the beriberi, what happens? The metabolic demand in the case of a thyrotoxicosis, the metabolic demand of the tissues is so high because of the increased thyroid hormone. What happens? you will need a lot of blood. So there will be a massive vasodilation in both beriberi, and in the case of thyrotoxicosis, the massive vasodilation will cause the pooling of the blood in the periphery. So even though the heart is pumping, the blood is getting pooled and the blood is not able to properly circulate. So these scenarios are what is being referred to as the high output failure. Okay, so the heart failure sometimes, like we refer to as the systolic failure, diastolic failure, high output failure, left heart failure, right heart failure, congestive heart failure. These are all the different terms, and the more details of how it happens, you study in the details of the pathology. But for us, what is important now is how this heart failure changes the physiological parameters, like what happens to the pressure volume loop. Okay, so what happens to the cardiac function curves. Okay, so let's see the further details of these failures. So this is just a brief introduction to different types of failure. So in the failure, what happens to the pressure volume loop? So this is what is being referred to over here. Okay, so the two things that you need to study for the heart failure is the pressure volume loop and the cardiac function curves. Okay, so first let's see the cardiac pressure volume loop. Okay, so in the case of a systolic failure, what happens? So this is your systolic line and this is the diastolic line. Diastolic line stays the same, but the systolic lines drops. Okay, the systolic line is dropping. Okay, so this is the graphical representation that we have studied for the Frank Starling's law, right? Hope you remember before. Okay, so what happens to the stroke volume? The stroke volume decreases. Okay, the stroke volume decreases. What happens to the, this is the end systolic volume. Okay, end systolic volume. What happens to end systolic volume? There is increased end systolic volume. Okay, and there will be decrease in stroke volume. So that's the major issue over here. So the stroke volume decrease is more evident in systolic failure than in the diastolic failure. In the diastolic failure, you can see the stroke volume is also further decreased, but not evident as that in the other. But here what is evident, this diastolic line over here is going up. So the diastolic pressure, so the heart is not able to fill the blood over there and the pressure is raised. Okay, so this is the pressure. On this y-axis you can see the pressure. So the diastolic pressure, which is not supposed to increase much, what happens to the diastolic pressure? You can see the diastolic pressure is increasing. Okay, so that is what happens in the case of a diastolic failure, and thus the stroke volume decreases. Okay, so now in either of these scenarios, whatever is the reason for the heart failure, whatever is the reason for the heart failure, or whatever the type of the heart failure, we need to understand what happens to the cardiac function curves. Okay, so this graph that is represented over here provides the cardiac function curve. Okay, so we are looking at the cardiac function curve. Cardiac function curve, you have two axes. Okay, the y-axis normally represents cardiac output or sometimes represents the venous return. Okay, or a combination of both cardiac output and the venous return. Okay, on the x-axis you have the right atrial pressure. Right atrial pressure. Okay, so the normal right atrial pressure is 0. Okay, and the normal cardiac output is 5. So this is the point where they meet. Okay, so in this graph over here, that point is represented by this A. So normal cardiac output. Okay, so the normal cardiac output is A. This is the 5 liter. Okay, and the normal right atrial pressure is 0. Okay, normal right atrial pressure is 0 and the cardiac output is 5. So this is the point at which it meets. Okay, approximately. So that's the point A. Okay, so now we are trying to see what happens to this cardiac function curve. Okay, when there is progressive changes in the cardiac output curve after an acute MI. Okay, after an acute MI. Good. Okay, so immediately what happens when there is an acute MI? There will be decrease. It's like a systolic failure. Okay, so acute MI can cause a systolic failure as the heart is unable to pump. So what happens? This will drop. The cardiac output will drop from 5 to a lower value. Say in this example it has gone down to the point B over here. Okay, so in this B, okay, what is happening? The heart has failed. Okay, the heart has failed and the value has dropped. The cardiac output value has dropped. Okay, so when the cardiac output is dropping, what is happening to the right atrial pressure? Okay, so that's important for you to understand. So in the right atrial pressure is going to increase because the heart has failed, but the blood is coming back. Heart is unable to pump the blood out, but the blood is accumulating over there. Because of this accumulation, what has happened to the right atrial pressure? It has increased. Okay, so the vena cava, the superior vena cava and the inferior vena cava is bringing the blood to the right atrium, and the right atrial pressure is increasing now. Okay, now what does the body do immediately? What is the immediate compensation? So there are two types of compensation that we have. One is the sympathetic. Okay, so the damaged heart. Okay, when it is the heart is damaged, what will happen? The first compensation, that is the sympathetic stimulation. Okay, so what does the sympathetic stimulation will do? Will act on the alpha 1 receptors. Okay, and cause the vasoconstriction. Okay, it will cause the vasoconstriction, and it will also cause the release of the epinephrine from the adrenal medulla, and epinephrine can act on the heart and on the beta receptors, and then cause the increased contractility, or the trying to increase the rate of the heart, but the heart is failing, but it will try to compensate for that. Okay, so by compensating, so actually what is done, because of the vasoconstriction and venoconstriction, the venous return is going to be increased. It's not going to be decreased. So what happens to the right atrial pressure? It is not going back to its original position of 0. Instead, it is further increasing from 4. Okay, it is going in this direction, going away from the normal. Okay, because of the compensation, and it goes towards the C. Okay, it has gone to the C value. Okay, in the C, what has happened? The right atrial pressure is further increased because of the venoconstriction and the vasoconstriction. The venous return is more, but the heart is not able to pump more. Okay, but it is trying to do that because of the sympathetic stimulation, and it has reached to that value. Okay, so now what is the next compensation? You have the next compensation, that is um, the RAS system. Okay, so the RAS system, so the partially recovered heart, in this one, what do you have? The RAS system. Okay, renin angiotensin aldosterone system. So because the blood flow is like decreased to the kidney detects that, and kidney will produce the angiotensin 2. Angiotensin 2 cause the production of the aldosterone will go and cause the retention of the sodium and the water. So the water accumulates. So when the water is accumulating, again what you are trying to do to the blood volume and the venous return, you are trying to increase that. When the blood volume and the venous return is trying to be increased, what happens to the right atrial pressure? It is further increased. Okay, it is further increasing, not going towards back to the normal of 0. But what is going back to the normalcy? The cardiac output has came back to the normal value. So the point A and the point D is the same. Okay, but it has compensated and reached to the normal value. It has compensated and reached to the normal value. So the person is surviving now. Okay, the person is able to survive. But you can see very clearly, even though the cardiac output, the y-axis is the damage is like brought back to normal, but this has gone away from the normal, far away from the normal than what is required. It has to be 0, but it has gone far away. Okay, so that means the blood that is getting pooled in the heart. Okay, so but there is compensation happened, and the cardiac output has came to the normalcy. Okay, so now if this person try to put an exert and effort, like try to climb or try to wake up fast or increase the heart rate, he can't do that because his sympathetic is already on high, and his RAS system is already on the all the compensation mechanism has gone to the high value. So beyond this he cannot make it. Okay, so he is already in a critical limit. Okay, this limit, this cardiac output limit that we need over here is referred to as the critical limit. Okay, so if the patient is able to do the compensation and reach to the critical limit, okay, we call that as a compensated cardiac failure. Okay, compensated heart failure. Okay, so what the graph is representing over here is the compensated. So next what we after describing this graph, we will go and describe the non-compensated. Okay, non-compensated cardiac failure. So first let us finish with the compensated. Okay, so now let us look. So we have been discussing about the right atrial pressure and due to the venous return and what are the problems. Okay, so let's put this venous return onto the y-axis instead of the cardiac output. Let us put the venous return on the y-axis and see what happens. Okay, how the graph will look like. Okay, so this is the venous return curve. This is the normal venous return curve that we have, the normal venous return curve. Okay, so the normal venous return curve, which is 5 and 0. So this is the points. Okay, these are the points that we have. Okay, so we have the points like 0, and whatever is the cardiac output, that should be the same. So the 5, this is the normal value of the venous return, and 0 is the right atrial pressure at that point. So this is the normal point. Okay, so now what happens if the right atrial pressure is more? If the right atrial pressure is like increasing, okay, if the right atrial pressure is increasing, okay, so what happens? So in order to understand that, we have to know what is the meaning of the word mean systemic filling pressure, which is +7, the mean systemic filling pressure or the peripheral venous pressure. So always the blood will flow from one point to another point like this, from a high pressure to a low pressure. That means the mean systemic filling pressure should be 7 and the right atrial pressure should be 0. Then only the blood can go. Okay, the venous return can come from like the periphery to the heart. Okay, so 7 to 0. So high pressure to low pressure. Okay, so now if you increase this 0 to 7, okay, what will happen to the venous return? No venous return. The venous return will become 0. Okay, so that is why the venous return becomes 0 when the mean systemic filling pressure and the right atrial filling atrial pressure meets together. Okay, so that is this point representing over here. It represents what? The mean systemic filling pressure and the right atrial pressure. If both of them are same, that means there is 0 venous return. Okay, but instead of that, if you change like 0 to say -1, so there is more gradient. Okay, there is more gradient, and what will happen? There will be more flow. There will be more flow, but you are making it into negative. Okay, you are making it into negative. So you can see, if I make it into -1, what is happening to the venous return? It is increasing. The venous return is increasing. Okay, but even though it is increasing, because you are creating a negative pressure, because you are creating a negative pressure, say by about like -2, what will happen to this venous return? It goes into a plateau. Okay, it goes into the plateau phase. That means you cannot further increase, because the negative pressure that is over there, the negative pressure that you have created, that causes the compression. Negative pressure is always compared to that of the atmospheric pressure, so negative than the atmospheric pressure, right? So that means if it is negative than the atmosphere, it will start, the atmospheric pressure will start to compress it, and then the venous return is not possible to increase further. So that is why it reaches into a plateau. So hope you understood this graph, the normal graph of the venous return. Okay, so now we will put this venous return graph into the cardiac function curve graph. Okay, this graph that we have seen over here. Okay, the cardiac function curve graph. Okay, so this is what we call as the cardiac function curve graph. Okay, so we will put in the cardiac function curve graph the venous return curve. Okay, and then see how it matches. Okay, so this is what is being shown over here, the same thing. Okay, so at point A, this is the normal. Okay, this is your normal. This point A is the normal. Okay, in the normal you have 0 and 5. So you can see both the venous return curve, the venous return curve, and the cardiac output curve. Okay, both of them are meeting at one point. That means the venous return and cardiac output both are equal to each other at that point. Okay, so now what happens? This point, okay, is dropping from A to B. It is dropping from A to B. Okay, it's dropping because of the heart failure. Okay, now when there is sympathetic stimulation, what is happening to the venous return curve? See, you can see this venous return curve has gone up. So this is your new venous return curve. Venous return curve. So you can see this new venous return curve is meeting the right atrial pressure, the 0 point. Okay, at a higher value, say for example over here 10. Okay, it's meeting at 10, supposed to be meeting at 7. Okay, it was supposed to be meeting at 7. So this has increased over here. That means this was the mean systemic filling pressure, the mean systemic filling pressure, and the mean systemic filling pressure has increased. Mean systemic filling pressure has been increased. Why it has been increased from say the value of 7 to 10? Because of the venoconstriction that has been created, and the venoconstriction that has been created caused the movement of this point B to point C, to a higher point. Okay, and the cardiac output function curve has been fallen down, and it has been like enhanced. So you can see the cardiac function curve that is on this line is increased by the sympathetic stimulation. Okay, because the sympathetic stimulation is providing the adrenal medulla to release the epinephrine. Epinephrine will go and act on the heart, and the heart efficiency is slightly increased. Okay, so that is also raising, and the mean systemic filling pressure is also increasing. Now what happens to the mean systemic filling pressure when we go towards the point D? Again, what is happening? The RAS system, renin angiotensin aldosterone system, is working and retaining the sodium and the water. So what happens to the mean systemic filling pressure? It goes to a point like, say, about like 12. Okay, that means the mean systemic filling pressure is again increasing. That means the venous pressure. So first was due to venoconstriction. Now you are adding more water to the veins, or the blood volume is being increased. So the mean systemic filling pressure is also again increasing. So you can see this line has gone further high. Okay, and again, because of that, what happens to the cardiac function curve? Because the angiotensin 2 and the ADH, etc., the acting, the cardiac function curve also slightly build up. Okay, so and what happens? It matches to that of the A. Okay, it reaches to the point equivalent to that of the point A. Okay, the starting point and this point is same. That means it has been compensated. Okay, so now if the patient comes in this scenario to the clinic, what the physician has to do now? The physician has to correct this right atrial pressure curve. Okay, this axis, the x-axis, has to be corrected. The y-axis is compensated by the body. The y is compensated by the body, but the x is far from the normal. 0 was the normal. Okay, it has gone from 0 to, or almost like a 6 value in this graph, you can see. Okay, so the right atrial pressure has gone from 0 to 6. So what is the aim of the physician? Is to correct the problem in the heart. The first aim is to correct the problem in the heart. If there is a ischemia, remove the ischemia and try to provide normal blood supply. Not only that, then the compensation has to be decreased, right? So that already a lot of fluid overload has been created, so the patient has to be given with the sympathetic overload is there. So you block the sympathetic or reduce the sympathetic, and also not like immediately, but after correcting the problems of the heart, it has to be done. You correct it and then give the diuretic. Okay, you have to give the diuretic. Okay, you have to give the angiotensin receptor blocker, or the to reduce the RAS system. Okay, or the ACE inhibitor, so that there is no too much production of angiotensin 2. Okay, so you reduce the ACE, reduce the or produce ACE inhibitor or the ARBs you give, and the angiotensin 2 is not working, or the aldosterone is not able to make work, or the kidney is not able to allow to retain the water. You give a diuretic and allow the kidney to lose more water. Okay, so these are all will be the approach to correct which axis over here? The x-axis. Okay, to correct the x-axis. Okay, so now this example that we have studied is for the compensated cardiac failure. Okay, so how a compensated cardiac failure is being represented, and how the treatment approach and the correction approach should be. Okay, so the physician knows this very clearly by looking at the cardiac function curve, whether the right atrial pressure has come back to its normal, etc. Okay, now what has to be done? We have to see the next scenario. In the next scenario, it is not compensated. Okay, this is a decompensated heart failure. Okay, the decompensated. That means by all these mechanisms, the mechanisms like what? The sympathetic, the RAS system, and all other hormonal mechanisms, and the body's compensatory mechanism, the critical cardiac output for the normal fluid balance has not been reached. Okay, so when that is 5, this is the critical value. Okay, this is the critical value that is very important for the maintenance of the life. And by the so the heart has been failed and has come to this point A. Okay, the heart has failed and this point. Now what has to be done? You are doing the sympathetic stimulation. Okay, and then changing this point from like the mean systemic filling pressure is shifted from here to here, like to the 10. Okay, so what has happened? The cardiac output has come to the point B, but you can see it has not reached the critical value. Not reached the critical value. So if the critical value is not reached, again the RAS system is trying to bring it up. The RAS system is fully functioning and it is unable to reach to the critical value. If all this compensation cannot bring it to the critical value, that is the normal cardiac output value, what will happen? The first organ, the kidney itself, will fail, okay, the heart itself will start to fail further. Okay, so once the kidney starts to fail, what happens? The kidney is unable to, kidney is already being reduced output, the urine output is being reduced because the increase is sympathetic, one reason, and the RAS system is another system, it's retaining all the water. So what happens? Not only the water will be retained, along with the sodium and the water, the other toxic material starts to accumulate. When the toxic materials like ammonia and the urea, etc., starts to accumulate, it becomes toxic to the brain and other organ systems in the body, and the heart also fail. So when the heart is unable to maintain the blood supply to the heart itself, okay, that act as a vicious cycle. So the cardiac output to the heart itself is not sufficient, so the heart itself is not getting any blood supply. Okay, so what will happen? The heart starts to deteriorate. Okay, so by the second day the compensation has reached over here, but the heart is now start to declining down, it is further declining down. So almost by a week time, what will happen? The patient will be dead. Okay, because the cardiac output will be so much dropped and all the toxins are accumulated. Okay, so this is called as a decompensated heart disease. Okay, so now this is without treatment. Okay, all these scenarios that we have shown over here is without the treatment. If the patient is not treated and if the patient is having a decompensated heart disease, what happens? That is, this graph is representing that. Okay, now let us see, if this decompensated heart failure patient is coming to the physician, what is his approach, what he has to do? So his primary approach is to bring the cardiac output to the critical value. Okay, so the severely failing heart, okay, what he has to do? He has to strengthen the heart, he has to increase the contractility of the heart. Okay, so what is the best drug of choice for increasing that? The digitalized or the digitalis group of drug. Okay, digitalis group of drug will block the sodium potassium pump, and the sodium calcium exchanger cannot work, the calcium will accumulate, and this calcium will strengthen the contractility. Okay, increase the ionotropy of the heart. So when it increases the ionotropy of the heart, the critical value will be reached. Okay, so if this is the failing heart, okay, and this is the red one, it has, instead of like this black line over here, it has gone up over here. So this is the new line that is created by the digitalis drug. Okay, but it cannot depend on that one forever, so you need to correct the other problem that is happening in the heart. The correction has to be done, but immediately if you want to strengthen the heart and maintain the cardiac output, then you have to give the digitalis and maintain it. Okay, again, all these scenarios, what is happening to the right atrial pressure, once all these things are being corrected, the aim will be to bring back this axis back to the zero. This is the value, normal value you need to get. How to get it? By allowing the, or after all the corrections are done, then reduce the sympathetic, reduce the fluid overload into the body. Okay, stop the renin angiotensin aldosterone system, like by giving diuretic, by blocking the angiotensin 2, by blocking the aldosterone, etc. Okay, you have to bring it back to the normal value. So this is what happens in the decompensated cardiac failure. Okay, so also we have studied about the high output failure. Okay, so high output failure, the reasons for the high output failures are what? Arteriovenous fistula, okay, thyrotoxicosis or beriberi, okay, thiamine deficiency or beriberi, and thyrotoxicosis, the one that you miss it, thyrotoxicosis. Okay. Thyrotoxicosis means extremely high output of thyroid gland, giving out a lot of thyroid hormones. Okay, T4 T3 is very high in the body. That is called thyroid storm or a thyrotoxicosis. Okay, so this is again the normal value. Okay, this value and this value, but you can see over here it is not going down. When the problem is there, the heart is increasing over here. Okay, so the cardiac output is like very high, it has increased, but what is the problem? This is in the arteriovenous fistula. Okay, when there is arteriovenous fistula, the blood is not able to be pumped into the organs. Okay, the heart is pumping, but it is going to the arteries and coming back through the veins, not going into the, there is a fistula between the artery and the vein, so it is not going into the capillary system. Okay, so that is what happens in the arteriovenous fistula. Okay, and also in the beriberi, it is not like decreasing, instead it is increasing to a value. Okay, the cardiac output is high. Okay, over here in the beriberi, because of the vasodilatation, the mean systemic filling pressure is shifted. Okay, shifted high, and it is increasing. So the problem is the thyrotoxicosis of the beriberi is causing a massive vasodilation, and the circulation is impaired, and the tissues are having a high metabolism in thyrotoxicosis and unable to maintain that. okay, is in requirement for a high oxygen demand, okay, etc. So that's what happens. So this is how the graphical representation look like, the cardiac function curve look like in a high output failure. Good. So now we have finished with the heart failure, and what are the two important graphical representation that we must know for the pathophysiology. One is the pressure volume loop. What happens to the pressure volume loop, the distinguishing factor between systolic failure and the diastolic failure, and the next one is the cardiac function curves, okay, how it looks like. Okay, okay, so now let's go to the next condition that is called as the circulatory shock. Okay, circulatory shock. Okay, so again, same like the heart failure we have mentioned, circulatory shock means whatever is the condition, that means is unable to provide the blood to the tissues. Okay, so means generalized inadequate blood flow through the body to the extent that the body tissues are damaged because of too little flow, especially because of too little oxygen and other nutrients delivered to the tissue cells. Okay, so that is what happens. Okay, so the heart become progressively more damaged when its coronary blood supply is reduced, okay, during the course of the shock. Okay, so that is the low arterial pressure that occurs during shock reduces the coronary blood supply even more. So this makes the heart still weaker, which makes the arterial pressure fall still more, which makes the shock still worse. So the process eventually becomes like a vicious cycle, okay, damaging. So it keeps on damaging. So the heart is pumping less blood to the heart. Heart becomes more weaker, and still it pumps very less blood, and again the blood supply to the heart becomes further less, okay, and it will lead into the cardiac deterioration. The heart will be keeping on deteriorating. Okay, so that's why it is referred to as a vicious cycle, like a positive feedback cycle. Okay, so the types of shock. Okay, the types of shocks. The most important type of shock that we need to study is the hypovolemic shock for the pathophysiological concepts. Okay, okay, cardiogenic shock, the one that we have just now described. Any reasons for the heart? Okay, like the systolic failure or the diastolic failure or the right heart failure, left heart failure, congestive heart failure, etc. Okay, can lead to cardiogenic shock because the heart is unable to pump the blood and the blood is not reaching anywhere. Okay, so hypovolemic shock we will come back to in detail. Okay, neurogenic shock, the nervous system failed. Okay, the neurons, like the sympathetic failure. Okay, so the sympathetic system is unable to maintain the sympathetic tone to the blood vessels, and the blood vessels is unable to maintain the pressure. So that is what is referred to as the neurogenic shock. Okay, anaphylactic shock is because of the anaphylactic reactions, the allergic reactions that you get. Okay, IgE mediated reactions or the mast cell degranulation, etc., causes what? Huge histamine release, and this histamine causes massive vasodilation, okay, throughout the body. So this massive vasodilation, same like that one that we discussed for the beriberi or thyrotoxicosis, etc., this causes massive vasodilation and unable to cause the flow of the blood. Okay, so that is the anaphylactic shock. Okay, the another one is septic shock. Okay, so this is happening due to the sepsis, maybe the bacterial infection or the gram-negative bacteria, sometimes some of the gram-positive bacteria also. So this will cause what? Sepsis. Okay, sepsis causes massive vasodilation and again unable to meet the circulatory demands of the tissues. So that's a obstructive shock. Obstructive shock means what? There is obstruction happening somewhere. Okay, so like for example, if the blood flow to one of the part of the body is like obstructed, either maybe due to like a massive blood clot or due to some like external force being applied like a tying or something, any of these can lead into obstructive shock. Okay, so one of the classical feature of all these shock is like neurogenic shock or the anaphylactic shock or the septic, especially this anaphylactic shock and the septic shock. There will be too much of blood in the periphery. Okay, so we call that condition as like warm shock. There is a lot of blood outside, but there is the problem is it is not able to meet the demand. Okay, so that is why the anaphylactic shock or septic shock is referred to as the warm shock, whereas the hypovolemic shock is classically referred to as the cold shock. Okay, there is no sufficient volume of blood at all. Okay, the blood has been lost. So what are the causes for the hypovolemic shock? Okay, so the hypovolemic shock can be occurring due to hemorrhage. Okay, there is a trauma, road traffic accident or any other trauma where there is a loss of blood. Okay, that is one reason to cause the hypovolemic shock. Hypovolemic shock can be caused by the plasma loss alone. Need not be the whole blood that is lost, like in the case of a hemorrhage, but it's only the plasma can be lost. Okay, that can also cause that. So what is that? The hemo concentration, increased blood viscosity. Okay, the problem when you lose only the plasma, it will cause a hemo concentration and increase the blood viscosity, because the RBCs are very tightly packed and the viscosity of the blood will be increased. Okay, what are the causes to lose the plasma? If you have intestinal obstruction, when you have an intestinal obstruction, what will happen? It will try to push it, so there will be a lot of fluid that is coming from the blood into the intestine to compensate for that. Okay, trying to overcome that obstruction. So in that scenario, what will happen? All the fluid from the blood is going into the intestine and the blood is having a lack of fluids. Okay, the plasma will be lost in that way. And severe burn, there is lack of protection from the skin, so the water all will be coming out of the blood vessels, or the fluid will come out, and this is also cause the hemo concentration, so the plasma loss. Okay, so in the case of a hemorrhagic shock, what is the best replacement option? That's the blood. But in the case of a plasma loss, the best replacement option is not the blood. You have to replace it with the plasma, because you can see over here, if you replace it, already there is hemo concentration and the blood is more viscous. If you give this patient more blood, his hemo concentration or the viscosity of the blood is going to further increase, which is not good for him. Okay, so when you have a plasma loss, it has to be replaced also with plasma. Good. Another condition is hypovolemic shock due to fluid loss, water loss. Okay, not just the plasma, the water is being lost. Okay, so conditions like excessive sweating, fluid loss in severe diarrhea or vomiting, fluid loss in nephrotic kidney, the kidney disease conditions. Okay, inadequate intake of the fluid or electrolytes. Okay, destruction of the adrenal cortex. Okay, adrenal cortex, if it is damaged, there is no aldosterone, so you cannot retain the sodium in the water, so you will start losing sodium in the water. Okay, so these are all causes for the hypovolemic shock. Okay, hypovolemic shock either due to dehydration, water loss, plasma loss, or blood loss. Okay, so these are the various conditions. So now let us see what are the features of this shock. Okay, so hypovolemic shock is called as cold shock. We have already described it, right? An example of the warm shock is what? The anaphylactic shock or the septic shock, etc. Okay, now the hypovolemic shock is characterized by hypotension. Okay, because the blood has been lost, so the blood pressure in the arterial system will be very low, so that is called as a hypotension. And the heart rate will be high. As a compensation, the heart rate will be high. So how will you see the pulse? The pulse will be rapid and thready pulse. Okay, thready because there is no volume to feel there, so it looks like very thready in nature. Okay, so that the going up and down, that feel won't come because there is less volume, so it will be rapid but it will be thready pulse. Okay, so a cold, pale, okay, clammy skin, moist skin, because there will be increased sympathetic output, and the increased sympathetic output will cause increased sweating, etc. So that's why the skin is very clammy. Okay, but the skin will be cold and clammy in nature. Clammy means the moist skin because of the increased sympathetic stimulation, and the person will show intense thirst because the fluid has been lost. Okay, and rapid respiration to compensate for the oxygen. Okay, and restlessness. Okay, sometimes, but it's not like a must. Okay, restlessness. Instead of that, sometimes some patients will show torpor, which is the inactivity or lethargy, like tired and exhausted feeling. Okay, so none of these findings, however, are like need not be like always present. Okay, some of them may be there, but always there will be what? Hypotension. And but hypotension may be what? Relative. So for example, a hypertensive patient whose blood pressure was regularly in this range, okay, when they go into shock, it may be in this range. So if you just read this value and the patient comes to the clinic and just read this value, you may feel, oh, this patient is having a normal blood pressure, but not, it's not like that. Whatever the patients had the blood pressure, it will be dropped due to the hypovolemic shock. Okay, so be careful with that. Like it is like a relative, so the hypotension is relative. These are the features. Okay, now what are the effect of hemorrhage on the cardiac output and the arterial pressure itself? Okay, so which one will fall first? Okay, so you can see the cardiac output is like can be maintained only like a up to like around like 10 percentage blood loss. Okay, 10 percentage of the blood loss, but the arterial blood pressure can be maintained approximately up to 20% blood loss. Okay, so this is because more compensations are available to maintain the blood pressure compared to that of the cardiac output. Okay, so cardiac output is the function of the heart, but as the arterial blood pressure is maintained by multiple compensatory mechanisms like the sympathetic and by the renin-angiotensin-aldosterone system. Okay, we'll see what are the list of the compensatory mechanisms. Okay, so now you can see in this graph, it is not like after a 20% loss, it is not like a sudden straight drop. Instead, you can see a small place where it is like trying to maintain it very effectively. Okay, so that means when the cardiac output and the arterial pressure drops to around like 50%, the blood flow to the brain will be like drastically dropping, and as a last attempt, the brain will be providing with like a very high sympathetic overflow. Okay, so that is why for a little duration you can see it is maintaining, but it's almost like the person is going to like, once that is also lost, the person will go certainly to zero cardiac output and the person can die. Okay, so up to this point it's possible to be maintained, but after this it cannot. Okay, so a person like normally have like say about like 5 liters of blood. That means like 10 percentage of like 5000 ml of blood. That means 10 percentage of that is how much, like around 500 ml of blood. So once you lose the 500 ml of blood, what is happening to the cardiac output? It is lost. Okay, once you start losing like around like 1 liter of blood, what is happening? The arterial, that is about 20, this is about like 10 percentage of the blood, this is about like 20 percentage of the blood loss. Understand? So once you like lose like 20 percentage, then you cannot maintain the cardiac output and it starts deteriorating unless a medical care is given and some fluid replacement etc or the blood replacement etc is not maintained. The person cannot survive. If the person lose 1 liter of blood, the person cannot survive. Even by losing like 500 ml, it's like it becomes hard because the cardiac output is dropping. Okay, it become immediate attention is required. So in case if you want to donate the blood, how much you can donate? It should be always below this value. So on an approximately like 300 ml is a good volume of blood that you can donate without any changes into the cardiac output and the arterial pressure. Okay, so what are these compensations that is maintaining this arterial blood pressure and the cardiac output even when the blood loss is happening? Okay, so which includes this all, like we have been studying before. So vasoconstriction, tachycardia, venoconstriction, tachypnea, increased respiration. This is also thoracic pump, increase the venous return. Okay, tachypnea. Okay, restlessness, the skeletal muscle pumping will be happen, and like what happens, the venous return helps to maintain the venous return. Okay, so increased movement of the interstitial fluid into the capillaries so that the blood volume can be maintained. Okay, so increased secretion of norepinephrine and epinephrine from the adrenal medulla. Okay, increased secretion of the ADH, vasopressin, of the ADH. Okay, don't forget about the AVP is another abbreviation for the vasopressin, arginine vasopressin, or the ADH. Okay, increased secretion of glucocorticoid. Increased glucocorticoids is the cortisol. Okay, the role of the cortisol is to maintain the blood glucose level. Okay, when the heart and the blood supply is getting reduced, you need to maintain the blood glucose level. So the cortisol helps for that, and it's also like a stressful scenario. So it is creating that increased secretion of renin and aldosterone, RAS system. Okay, that's very important system. That's your RAS system. Okay, and increased secretion of erythropoietin, because when the blood like hemorrhage is there, you need to, the blood loss is there, so the RBC protection has to be increased, so the kidney will produce a lot of erythropoietin. Okay, increased plasma protein synthesis from the liver. Okay, so the blood is being lost, and to maintain the plasma osmolarity, so and the albumin secretion, the albumin maintains the oncotic pressure. So to maintain that, the liver will try to produce more plasma proteins. These are the compensatory mechanism that we have. So now, as a treatment approach, what is the treatment approach we can have? Okay, so the treatment of the shock should be aimed at correcting the cause and helping the physiologic compensatory mechanisms. Okay, and you should not remove the physiological compensatory mechanism. For example, a hypovolemic patient will be in like a shock and like feeling cold. The skin will be cold and shivering. So if you put a blanket on this patient and allow to warm him up, what happens? The blood supply to the periphery will be increased, and then his shock will be more severely worsened. Okay, so we should not try to remove any of these compensatory mechanisms. Okay, so this is helping, the physiological compensatory mechanism is helping to maintain an adequate level of tissue perforation. So in hemorrhagic, traumatic, and surgical shock, for example, the primary cause of the shock is the blood loss, and the treatment should be include the early and rapid transfusion of adequate amounts of compatible whole blood, depending on if you are having hemorrhage. Okay, but saline is of a limited temporary value. You need the blood itself in that scenario. The immediate goal is restoration of an adequate circulating blood volume. Okay, and since saline will be distributed in the extracellular fluid, so only 25% of the amount administered stays in the vascular system. So that's why saline will be of less value. Okay, you need to provide the blood transfusion as well. But in like condition like in the burn or like the plasma loss, the in which there is hemoconcentration, so the plasma is the treatment of choice. Okay, the treatment of choice is what? The plasma. So that the restore the fundamental defect, the loss of the plasma. If you give the blood, what happens? It will cause the more hemoconcentration to happen. Okay, so this point you can keep in mind. So for the treatment approach. Okay, so let's see the special features of the traumatic shock. Okay, now in the case of special features of the traumatic shock, okay, so develops where there is damage to the muscle and bone. Okay, so in some conditions when there is a road traffic accident, what will happen? There will be damage to the muscle and bone. So this type of shock seen in battle casualties and automobile accidents. Okay, and also frank bleeding, open bleeding into the injured areas. Okay, is the principal cause of the shock. Although some plasma enters into the tissue, the amount of blood which can be lost into an injury that appears relatively minor is remarkable. For example, the thigh muscles can accommodate about 1 liter. For example, a road traffic accident and the femur is ruptured and a big artery is ruptured, the femoral artery is ruptured over there. What will happen? The blood will go and it will get accumulated in the thigh itself. Nothing like will be lost to outside of the body. Okay, there you may not even see any blood loss prominently, but the thigh is holding how much? Almost like 1 liter, which is like 20% of the blood. And what will happen to the arterial blood pressure and the cardiac output? It starts to suddenly drop. Okay, so for example, with an increase in the diameter of the thigh of only 1 centimeter, so you won't even observe that. Just like 1 centimeter increase in the thigh diameter will not be like easily visible, but there is almost like 20% of the blood is lost into the thigh. Okay, so that is possible without even like the blood lost to outside of your body. Now, what is the other problem? The breakdown of skeletal muscles, the rhabdomyolysis. Okay, so it's a serious additional problem when shock is accompanied by extensive muscle crushing. So we call that as the crush syndrome. Okay, so rhabdomyolysis means what? The muscle is ruptured and the myoglobin is coming out. Okay, when the muscle is ruptured, the important thing that comes out of the muscle is the myoglobin. Okay, so what will happen? The myoglobin will go and block the kidney and cause the kidney damage. Okay, so the kidney damage is also common in crush syndrome. It is due to the accumulation of myoglobin and other products from the reperfused tissue in kidneys, in which the glomerular filtration is already reduced by shock. So this myoglobin will go and block the nephrons. The glomerulus will be blocked. Okay, so the products damage and clog the tubules, frequently causing anuria, which may be fatal. Okay, when the glomerulus is like blocked, the toxins cannot go out, and a fast accumulation of the toxins will happen, which can go and affect the brain. And so in the rhabdomyolysis, this is an additional problem. And the problem is in the bone. When there is a bone fracture, the contents of the bones can come in and go to the blood, and like it contains fat. It can lead into fat embolism, etc. So those are like additional features that you can get. In this lecture, we will study about the microcirculation that is taking place in our body. Microcirculation means the circulation through the capillary network. The microcirculation means the circulation through the capillary network. So the important like pathophysiological concept that you must understand with regarding the microcirculation is the concept of edema. Okay, so let's discuss what is this like microcirculation. So like in the histology, we'll study about different types of endothelials, like loosely bound or like very tightly bound, etc. Okay, so the endothelium, like the capillary network have like endothelium, and then the basement membrane, and then there is like the intracellular cleft. Okay, the plasma lemma vesicles, vesicular channels. Okay, so these are the endothelial cells that forms the capillary. So before the start of the capillary, Okay, the capillaries originate from the arterioles goes to meta-arterioles. Okay, and before it goes into the capillary network, we have the precapillary sphincter. So the opening and closing of the precapillary sphincter control the blood flow through the capillary network. So in the previous lectures, we have studied about like what can cause the control of the precapillary sphincter, like for example oxygen, lack of oxygen, hypoxia, increased carbon dioxide, increased hydrogen ion, potassium ion, adenosine, etc., will cause the opening of the precapillary sphincter and increase the blood supply to that part. Okay, so that's the regulation. Okay, and what is this role of this microcirculation is to provide the nutrients and oxygen, etc., to the tissues. So these are the tissues that we have. Okay, so the things will come out of it. Okay, and the things will go in to it. Okay, go back to it. So especially in the arterial side, it will all like coming out. In the venous side, most of them it will be going back in. Okay, and anything that additional things that accumulates over here or like in the interstitium will be taken up into the lymphatic vessel, and the lymphatic vessel again go back and connects to the blood circulation itself. So lymphatic circulation is like starting from a blunt end over here, and then it is going back and like joining into the blood circulation itself. Okay, so we'll discuss about the lymphatic circulation and the role of this exchange, how the things come out and how the things go back. So the fluid has to come out of the blood vessel and provide the nutrients, and the fluid has to then go back in. Okay, the cells don't come out. Okay, only the fluid and the electrolytes and the nutrients that is required that comes in and out of it. Okay, so what are the factors determining the fluid movement across these capillaries? So this is a topic that we have studied with our renal chapter for the GFR, right? The glomerular filtration and what are the factors that controls the glomerular filtration, etc. So it's the same thing over here also. It is the capillary pressure, the hydrostatic pressure, which is abbreviated as the PC. Okay, this pressure allows the fluid to move out. Okay, allow the fluid to go out. Okay, out, and there is a osmotic pressure, the plasma colloidal osmotic pressure, which is abbreviated as the pi p, which attracts the water. So this is your arterial side and this is your venous side. So this will attract the fluid over here. Okay, now in the interstitium, what is there? The interstitial fluid pressure, the hydrostatic pressure. Okay, the hydrostatic pressure, which opposes the filtration. Okay, or supports the movement of the fluid back to the veins. Okay, and the interstitial fluid colloidal osmotic pressure, that is the proteins over here. Here this is normally very less unless in the pathological condition you don't have much proteins in the interstitium. Okay, there is no proteins in the interstitium, so normally this value equal to 0. Okay, but in a pathological scenario where there is infections or inflammations happening, there will be the proteins accumulating over here, like antigen antibodies can accumulate over here, can attract the fluids and then cause fluid accumulation and edema. Okay, so the net filtration is calculated by the capillary hydrostatic pressure minus the interstitial hydrostatic pressure minus the plasma colloidal osmotic pressure plus the interstitial colloidal osmotic pressure. This specific force equal to 0 normally. Okay, whereas the other have the specific values. Okay, so let's see what controls it. Capillary hydrostatic pressure is controlled by the pressure that is coming from here from the heart. So if there is fluid less flow, there will be more pressure over here. Okay, less, like the fluid is accumulating over here, there will be more. Okay, and the plasma colloidal osmotic pressure is mainly provided by the albumin coming from the liver. So if you have a liver damage or a kidney damage, if you lose albumin or albumin production is less, this pressure will be less, and the fluid that comes back to the blood vessel will be decreased, and the fluid will accumulate over here and cause the edema. Okay, so another thing that can cause edema is the increased interstitial fluid pressure. So in order to adjust this interstitial fluid pressure and the interstitial colloidal osmotic pressure, there is lymphatic vessels that is running over here, and this takes up and goes. So if you block this lymphatic vessels, for example in elephantiasis, like filarial worms, okay, the parasites can cause the blockage of this lymphatic vessel. Or if there is a cancer or a lymphatic node is like blocked, then what will happen? The cancer of the cancer or something is blocking your lymphatic vessel, the fluids cannot escape through here, and the fluid will accumulate here in the interstitium and create edema. So these are the various reasons that you must know. It's the same thing that we have studied in your kidney chapter. The renal chapter, we have discussed a lot about this, the glomerular filtration pressure, but make sure you revise that topic for here now again. And you understand the concept of the edema. Okay, so capillary and the formation of interstitial fluid. Okay, so the capillary. So how do we like the movements? It is through the rivulets of free fluids are there. Okay, through which the fluid can pass through. Okay, and the free fluid vesicles are also there to supply the fluids. Fluids means it includes the electrolytes, nutrients, etc. that can supply to the tissues. But if the tissue is very far from the capillary, it cannot supply it. Okay, so you need the capillary to grow into that tissue. So one of the classical scenarios seen with a tumor when it is growing, the first thing that it has to grow is the capillaries. The capillary network has to grow into that. So one of the easiest treatment approach is what? To prevent this angiogenesis. Okay, the new formation of the capillaries has to be prevented so that the tumor cells does not get the blood supply. So if the tumor is growing away from the capillary, it cannot get the blood supply. So the blood vessel has to grow into that. So preventing that growth of the blood vessels into that is one of the treatment approach for that. Okay. Now the regulation of the microcirculation, right? That is the precapillary symptom. Okay, so this is your precapillary symptom. So that determines whether the blood has to go into the capillary or just bypass this capillary and go out. Okay, so it will come from here and just go out over here without going into the capillary and supplying to the tissues. Okay, so what is they are the vasodilator theory and the oxygen lack theory or the nutrient lack theory. So if the nutrients, for example, the cells over here is undergoing metabolism, it will produce like metabolic byproducts like adenosine or potassium, hydrogen, or use oxygen and lack of oxygen, etc. This will create the uh, uh, stimulus for the precapillary sphincter to dilate and cause the fluid to go in, or the capillaries to go in. So the vasodilator theory is also representing that the property of the blood vessel, especially in the arterioles or in the veins. Okay, that also we have discussed before in the hemodynamics topic. Okay, so let's go into the lymphatic circulation. Okay, that is the one that is taking away the proteins that is present in the interstitium. Okay, absorption of the proteins from the interstitium. Okay, and the transport of fat and other nutrients from the GI tract, the transport of the fat, and because the fat molecules are large, it cannot directly go into the blood vessels, so it is taken up by the lymphatic circulation and then given to the blood circulation. And the balance between the plasma and the interstitial fluid, that is the major thing. So if this lymphatic vessel is blocked, what will happen? The interstitial fluid will accumulate and it does not go back to the plasma. So it will accumulate over there and creates edema. Then the protection, that is the immune system function. The lymph nodes have all the immune cells and then it helps for that. Okay, so this is another topic for the blood chapter and for the immunology chapter. Okay, so now the how does this lymphatic vessels work? So lymphatic like originate like in a blunt origin. Okay, it does not originate from anywhere, just originate from the tissues. Okay, and there are gaps between these endothelial cells of that. Okay, and they act like a flap and the fluid can enter in and cannot go out. It gets trapped over here. So it once the fluid enters over here, it cannot go out. So if there is a fluid accumulation here in the interstitium, the fluid will all enter in. Okay, the fluid will enter in, but the fluid when it tries to go out, there is like a flap like system or the valvular system which prevents the backflow or the flow out of the vessels. Okay, so that is the mechanism. Now let's see, once the fluid is here, it has to move to the blood vessels, right? It has to go and join into the blood vessel. So how does it move? Through the lymphatic vessels. So how does the lymph flow is happening? So interstitial fluid pressure, that is the primary one thing, the first thing that happens. So because the fluids are accumulating in the interstitium, when there is more pressure, it will cause the entry of it. So that is causing it to keep on pushing the lymph to move ahead. Okay, into towards the blood vessel. Okay, upward. Okay, so and the lymphatic pump, so the smooth muscles on the walls of the vessels automatically contracts when stretched. Okay, so there's like a property so that the fluid does not accumulate, they undergo contraction and the fluid keeps moving upward. And the external intermittent compression, so by the contraction of the skeletal muscles and the pulsation of the adjacent arteries. Same way for the venous return we have discussed, you need the contraction of the skeletal muscle. Same way for the lymphatic transmission also you need that. So when the skeletal muscle is contracting from both the sides, what happens? This will cause the compression and the lymph will move forward. But if it cannot move downward because of the valves, you have the valves over here. So the valves will prevent the entry backflow of the lymph. Okay. So now let us see the next topic. Okay, so that is the exercise physiology. Okay, so what happens in the exercise physiology? What happens to the cardiac output and the venous return? Okay, so you can see very clearly over here. So the A point is the resting, where you have the, it is 0 and this is like 5. Okay, the cardiac output and the venous return is 5, right atrial pressure is 0. So this is the mean systemic filling pressure, which is 7. Okay, so from the point A, how does it go all the way up to this point B during the exercise? Okay, how is the cardiac output being increased? What are the factors that is happening? So what happens? The sympathetic and the RAS system, etc., starts to work very efficiently, and the heart is like very efficient to accept all these mechanisms. And what happens to the mean systemic filling pressure? That is increased because of the venoconstriction. Okay, the venoconstriction. So at this point it becomes 0 now. Okay, so the venous return becomes 0. So like the mean systemic filling pressure is moved up to like around 20 value. Okay, and then the sympathetic stimulation to the heart will bring the cardiac function curve, that this curve to upward. Okay, this is going up, and the venous return curve is also moved up. Okay, so the venous return is also increasing and the cardiac output is also increasing during the exercise. Okay, and this is just like the representation of how the exercise, the changes happen. Now let us see what are the influence on the blood pressure. Okay, how does the exercise influences the blood pressure? So there will be increase in the stroke volume. Okay, of course, when the heart rate is like increased and the cardiac strength is increased, what will happen? There will be increase in stroke volume and increase in heart rate. Increase in stroke volume and heart rate, you multiply them, what will happen to the cardiac output? There will be increase in cardiac output. So the maximum heart rate that you should attain during the exercise is the value 220 minus your age. Say for example, if your age is like 20, the maximum heart rate you can attain is 200. Okay, 200 if your age is 20, so 220 minus 20, so 200 is the maximum heart rate you should attain. Okay, so stroke volume times, so your cardiac output is increased. Okay, so but because of the exercise, just now we have studied, now what happens, the precapillary sphincters will be dilated, because when you are doing exercise, what happens, there will be increased oxygen utilization, so it will create hypoxia, increase carbon dioxide production, and the carbon dioxide will produce hydrogen ion, there will be release of the potassium ions, adenosine, etc., will cause what? Vasodilation, and the precapillary sphincter to dilate, a lot of blood supply. So what is happening to the peripheral vascular resistance? That is decreasing. Systemic vascular resistance decreases. Okay, so there is the some like the product of cardiac output and the peripheral vascular resistance is the mean BP. Okay, so when you do this product of these two, there is no uh, change in the mean BP, because this is increasing, and this is decreasing, because this is decreasing. The systemic filling pressure, the peripheral vascular resistance is decreasing. So the sum of that is the mean arterial pressure. Mean arterial pressure remains same. Okay, so cardiac output times total peripheral resistance. So cardiac output is increasing, total peripheral resistance is decreasing. So there will be only a small change in the mean arterial pressure, not much change in the arterial pressure. But what happens to the pulse pressure? Because the systolic pressure is increasing, because the stroke volume is increasing and the heart rate increasing, cardiac output is. So what happens to systolic pressure? Systolic pressure will be increased. And what happens to the diastolic pressure? Because of the vasodilation, it will be decreased. So what happens to the pulse pressure? You will see the increased pulse pressure or the widened pulse pressure. Okay, you will see the widened pulse pressure. That is what happens in normal exercise, except in certain conditions like periodic large increases in mean arterial pressure will be seen in when a person is doing exercise and is associated with Valsalva maneuver. Valsalva maneuver means, already we have discussed, like when you are trying to expire out and you hold the breath. Okay, for example, weightlifting. The classical thing that a person do is like weightlifting. So when a person suddenly do a weightlifting, the blood pressure can go very high. Okay, so that's what happens in the Valsalva maneuver. Okay, so that's about the exercise, the changes that have seen in the exercise. Okay, now the other topic that we can cover, like small minor topics, like include the cardiopulmonary chemosensitive receptors. Okay, so this is like for example, when you see a postural hypotension, etc., when a person see emergencies in it, or see a blood or something, what will happen? The vagal reflex will be initiated, the vagal tone to the heart will be increased, and if the vagal tone to the heart is increased, what will happen? The heart rate will go down. So that's what we are trying to see. So the syndrome of the cardiac slowing with hypotension, okay, with hypotension, okay, that is called as a vagovagal syncope. The person will faint, has been attributed to the activation of a reflex called as the Bezold-Zarisch reflex. Okay, let's see what is that. So the vasovagal syncope can occur after prolonged upright posture that results in pooling of blood in the lower extremities and diminished intracardiac volume. Okay, also called postural syncope. Okay, this is one reason. So this phenomena is exaggerated if it combined with dehydration. If the person is dehydrated, so the postural syncope will be more severe. Okay, so the resultant arterial hypotension is sensed by the carotid sinus baroreceptors, and afferent fibers from these receptors trigger the autonomic signal that increase the cardiac rate and contractility. So that is the normal phenomena that should happen. But however, the pressure receptors in the wall of the left ventricle respond by sending signals that trigger paradoxical bradycardia and decreased contractility, resulting in sudden marked hypotension. Okay, so this is associated with what? The Bezold-Zarisch reflex. So Bezold-Zarisch receptors are the which is paradoxically behaving and causing what? The bradycardia, which is not supposed to happen when there is a dehydration, or when the blood flow is less. You are supposed to increase it, but paradoxically it causes increased vagal tone. Okay, so that is why this phenomenon is happening. So the individual also feels lightheaded and may experience a brief episode of loss of consciousness. Okay, so these are the topics that we have discussed under the pathophysiology of the heart, okay, of the cardiovascular system. Okay, so thank you.